They want to understand what means comprehensive molecular profiling.
Sure. Well, I think that, the question comes up of the difference between we do want to now get everything that is definitely clinically relevant, not just to have, not just to get 3 or 4 of the greatest hits, but we don't want to miss the emerging targets that are now relevant that maybe people weren't thinking of a year or two ago. The RETs, the METs, things like that, and also rare mutations. It could be KRAS G12C or EGFR exon 20. I mean, there's various ones that may not have a standard therapy that do have clinical trials. So I think that the key point is that today it makes overwhelming sense to be testing for everything that is relevant and has a treatment now, ideally also for everything that has various promising clinical trials. And I think that the next question is whether, and as Pasi was speaking, I'm wondering about, is it clearly necessary or overwhelmingly better to be comprehensive beyond 100 genes? And frankly, I'd be interested in your thoughts, Pasi and Weiss and maybe others, about, is more better beyond that point? Because I do worry that beyond a certain point, it becomes more confusing and we may be diluting our ability to detect what's truly important and chase down some of the wrong things. But Pasi, can you give your thoughts about, whether, presuming we capture everything that is useful now, going far down the long tail is desirable to you or not?
I think as an initial diagnostic test, probably not. I think you are able to capture most, if not all, of the things where we have therapies, targeted therapies. It may be different in the resistance setting where things can be broader and you're sort of looking for known things and maybe more unknown things as we're still trying to understand the comprehensive nature of resistance. So that may be an area where I would want to have a broader panel. But I think as an initial molecular workup in someone with newly diagnosed lung cancer, I think that the 100 gene panel is good. I will just make one comment that sequencing is better, I think, than looking at specific hotspots, because many of the hotspot assays don't, for example, capture all the exon 20 insertions that you alluded to. And so I think sequencing is better than hotspot assays in my mind.
I think we agree in that one. Maybe we don't need to do hundreds of genes, but also it's important that we go above the minimum, because the problem that we have, for example, in South Florida or in Florida State is that some companies only do the minimum number of genes that are the genes that are FDA approved. Then the patients are not eligible for clinical trials.
Right.
And at some point, the patient is going to need a clinical trial. So that's why we need a minimum number of genes, either 70 or 100. So because we need to have an option for the patient for the future. That's why I think I don't agree with the hotspots too, because we don't need 500 genes maybe, but we need a minimum number of genes to cover all the potential clinical trials. Okay, so we have another question, maybe for Jared. There's a question about if all the liquid biopsies are equally accurate to identify mutations and fusions.
So I'm aware of no comparative data between the different liquid tests. They've each done separate tests comparing themselves to tissue as gold standard or trying to show where they're complementary. As a clinician consumer, I guess the same perspective we were discussing different tissue tests with, I see them as more similar than different. I think the fundamental idea is that you have a test that doesn't require a physical biopsy, that can integrate potentially different changes over space, and that is fast. And you're using it to pick the low-hanging fruit, or when you don't have access to a tissue biopsy. I think the others can chime in if you feel differently, but I don't have a lot of passion between the different liquid tests in the way that I do have some passion about the prior conversation about the difference between tests modalities on tissue, going from a la carte PCR, FISH, or NGS hotspot to more comprehensive DNA, primarily DNA-based NGS assays, to NGS assays incorporating a good RNA fusion panel. In that progression on tissue, I found real fruit in picking up things that I can use for the benefit of patients. I found EGFR and ALK on NGS that weren't found on PCR and FISH. I found RET, NTRK, and METDEL14 on RNA fusion panels that weren't found on primarily DNA panels. In contrast, I really don't think there's a lot of fruit to be picked in comparing the different liquid panels to each other. But I invite others who might think there is more of a difference than I perceive.
Maybe one comment on that: the rearrangement detection is at a DNA-based assay, even for tumor sequencing, is still the one that is most variable. And I think that gets even harder from a liquid biopsy sometimes. So sometimes you don't find it on the liquid biopsy, you find it on the RNA-based analyses, as you said. So I think that's one thing just to keep in mind.
Can we explore a little more the RNA testing question? Because, I struggle with this and I don't know what the right answer is about it. You can always, I know that the sensitivity is greater if you add RNA testing beyond DNA, but at the same time, I do have concern that we need to focus on getting a straightforward message that's feasible out to the broad community, that you just need to look for the high yield things. And I'm afraid of, if it gets too complex, people won't follow any of it. And so I don't know is it feasible? I think, yes, you can always do more, but if we want to have a concise, clear answer and just make a rule that you should send off DNA NGS testing on everybody, is that a good message to start with? Or, do others feel that we need to push harder on that, even at the risk of confusing folks?
I think it matters what is becoming cost effective, Jack, because if you're going to have a patient, for example, I'm Peruvian, a non-smoker Peruvian female has a very high chance to have EGFR. Maybe you don't need to do an RNA testing, but we have a small kid with a fibrosarcoma that we know that he probably has an entry fusion. We need to run an RNA testing because we don't want to miss fusion. Or the same as you have a salivary secretory cancer or breast cancer. That's why I think I know that commercially there are 2 big platforms now that they automatically do RNA for everybody. I don't know if it means increasing the cost, but if it's going to be increasing the cost, I think it's not going to be maybe cost effective, So I don't know.
I think it's actually, in looking at the intersection between the technology and the practicals here, I think it's actually more complex to talk about lots of different tests, sending off a less expensive test or speaking in vagaries. In some ways, I think if docs just could hit the easy button and send off one sensitive test a priori, that might actually be simpler than saying, okay, get the DNA test. Then if you don't find an actionable oncogene, do you have Archer at your institution? Well, if you're asking the question, you probably don't. So then are you going to send off a Foundation Heme or a Tempus or something at that point? It may be, I think that community docs are understandably frustrated by the complexities, and I'm not sure any of us make it better by speaking vaguely about characteristics of tests. It might be more practical to just send off a one-stop shop and be done.